Well, I'd like to now give a couple of case examples. And the first I'm going to direct to Corey Langer. Let's say that you have a relatively young, never-smoking woman who is diagnosed with stage 4 adenocarcinoma of the lung. And you do reflex testing, and that patient has an activating EGFR mutation. What is the frontline therapy of choice in 2013?
2013, the frontline treatment is erlotinib. We have 7 and counting prospective randomized phase 3 trials in either a phenotypically identified group and, more importantly, increasingly mutation-identified group, where frontline treatment with a TKI leads to a far better response rate, far better progression-free survival than we would ever observe with chemotherapy. The IPASS trial was really a game changer in terms of how we approached these patients. Whether other TKIs will ultimately take over this field, I think, remains to be seen. Certainly, we've seen recent phase 3 data for afatinib versus systemic chemotherapy versus PEM cisplatin, which pretty much shows the same results, markedly improved response rate and progression-free survival. We've not yet seen a head-to-head comparison of TKIs up front in the mutant population. I'm not sure when that's going to happen. I'm sure plans are afoot to do that. But until that occurs, at least in 2013, erlotinib will be the standard.
There is, I think, an ongoing afatinib versus gefitinib trial in the EGFR mutant populations.
Abroad, outside
yes,
the
yes,
US.
Outside the U.S. But again, the first example of a head-to-head TKI comparison, of course, for those of us in the U.S. where we don't have gefitinib, it's going to be hard for us to know how do we use that in our practices when that data is available.
Does it extend to erlotinib?
Exactly.
I think the one thing we do know is that the sensitivity of EGFR activating mutation positive cancers is extraordinary compared to wild type. So whether it's gefitinib or erlotinib or afatinib or another TKI, at least for frontline purposes, all of those drugs are going to result in a high response rate. Would everybody agree with that?
Yes.
Absolutely.
Yeah, absolutely.
I think the other point from the IPASS and these studies and the others, and one that's probably mostly common knowledge now, is the use of the empiric use of the EGFR TKI inhibitors in the frontline setting is not to be used. And you can't say that strongly enough, again, given that data. And I think that happens a little bit still out there, and I think that it's important that really not be the case.
A person who phenotypically looks like they have the mutation but tests wild type is probably better served with chemotherapy up front.
Well, Alan, let me ask you about a second case. Let's say that a patient presents with stage 4 non-small cell lung cancer. It's an adenocarcinoma, and you do reflex testing, and this patient has an ALK fusion by the FDA-approved break-apart fish assay. What should be the first-line treatment for stage 4 lung cancer in this patient? Is it chemotherapy or is it a targeted agent?
Again, I think the answer is yes. It's both are reasonable. The indication, the approval for the indication, of course, is regardless of line of therapy, and you absolutely can use it for first-line therapy. There's fewer patients who have been treated in that fashion, but it is how I offer to my patient population. I do offer crizotinib in the frontline setting. I offer, we actually had the clinical trial, that phase 3 study of frontline chemotherapy versus crizotinib, and I asked a patient of mine if they'd like to participate in the study. And they looked at me as if I had two heads and said, why would I want to do chemotherapy first? So they ended up not going on the study. But it is reasonable. It may well turn out that it doesn't matter what order in which you get it and that the survival is going to be the same. We don't have the same amount of data, though, for that. And so I don't know that we can say it as convincingly as we can for the EGFR mutation, but I'm comfortable.
Yeah, I mean, playing devil's advocate, we have no data in the first-line setting comparing that. Now, we have recent data in the second-line setting suggesting that crizotinib is better than standard second-line cytotoxic chemotherapy. And as I said before, I think the same the story of the EGFR mutation is going to be true for the ALK translocated patient. I use it in the first-line setting myself, so I don't hesitate doing it. But from a purist point of view, we don't yet have randomized data. This is also a population that appears to be more sensitive to pemetrexed-based therapy, so that's not a bad option for these patients. And that's often, since almost all of them are adenocarcinomas, that would be certainly a reasonable choice in the first-line setting, with or without bevacizumab.
It's intriguing. It's the randomized trial in the second-line setting that really brought out the pemetrexed
Exactly.
information.
Well, there
Although-
were hints in retrospective studies, but this is a very nice example. Yeah, prospective.
So there is a utility to these trials, but I agree with you. If I have a patient who's newly diagnosed who has an ALK translocation, I will uniformly use crizotinib up front.